History of the present illness. The patient was apparently asymptomatic about 20 days back when, on the night of 6th June, he went to bed all right. On waking up the following morning, on 7th June, he noticed a tingling sensation in both his hands in the form
The
of
patient
pins
was
and needles
apparently
pricking.
asymptomatic
The
about 20
tingling
days
was
back when, on the night of
the
6th
tingling
June,
was
he
not
went to bed.
distressing and he was able to perform his activities of daily living without any problem. In the morning, he was able to get out of bed himself, stand from a sitting position, walk himself to the washroom, and had no difficulty in squatting in the washroom or standing from squatting position. He had no difficulty in holding objects, no difficulty in brushing teeth, opening the tap, combing his hair, buttoning and unbuttoning his shirt, wearing his trousers, or bringing down objects from the overhead shelf. By afternoon, while the patient was eating his lunch, he realized he started experiencing some difficulty in breaking his chapatis, picking up vegetables off the plate, and holding his food firmly in his hands. Despite the difficulty, he was still able to eat by himself, although it required significantly more effort to do so. While eating, he could appreciate that the food in his hand was hot, and while washing his hands, he could appreciate that the water from the tap was cold. Sometime later, he realized that the tingling had now progressed to involve his forearms and his arms. This was distressing for the patient, and he decided to seek medication for the same. While leaving the house and putting on his chappals, he had some difficulty in putting on the chappals, but was able to do so by himself. While walking to the market, he could see and feel that the chappal was slipping out of his foot, but was unable to grip onto the chappal tightly to prevent the slippage. At this time, he also began experiencing tingling in both his feet. While trying to
To
repeatedly
repeatedly
adjust his
adjust his
slippers,
slippers,
he tripped
he
over a
tripped.
stone and fell, but even at this time, he was able to get up by himself without any assistance. On his way back home, he noticed some buckling in his knees and had some difficulty walking back home and realized that the tingling from his feet had now progressed up to his knees. He was still able to walk back home by himself and was still able to hold his mobile phone and medications in his hands. However, it required significantly more effort to do so. On returning home, the patient felt very tired and went straight to bed around 10 p.m. The following morning, on 8th June, he woke up and realized that he was entirely unable to move any of his limbs, sit up in bed, or even roll in bed. He was, however, able to lift his neck off the pillow in an attempt to call out for his family. During this time, he had no difficulty in passing or holding urine while in bed or feces, and subsequently arrangements were made for toileting him in bed. The same day, the family took him to District Hospital Ghatampur, where he was admitted for a duration of 12 days without any resolution of symptoms. He was then referred to District Hospital Jahanabad, where a provisional diagnosis of quadriparesis was conveyed to the family. He was evaluated and treatment, but with no resolution. He was subsequently referred to our hospital for further management. Uh, One significant history that I would like to point out is that before the onset of this weakness, the patient reports a history of binge alcohol consumption for an entire week prior to the onset of symptoms, amounting to 3 to 4 quarters of country liquor per day, which is equivalent to 210 to 240 grams of alcohol per day for one entire week. There is no history of preceding fever, abdominal pain, loose stools, cough, expectoration, shortness of breath, or running nose. There is no history of neck pain, overhead weight bearing, trauma to the neck. There is no history of recent immunization. There is no history of high colored urine, rash, similar episodes of tingling sensation in the past. No associated numbness. No history of weight loss, night sweats, exposure to paints in the recent past, consumption of canned foods or seafood. No recent history of travel, no history of any insect bite or animal bite, no history of any changes in the voice, no history of difficulty in swallowing food, no nasal regurgitation of food or deviation of angle of mouth, double vision, loss of consciousness or seizures. There is no history of any high risk behavior. There is no history of any band like sensation over the chest, abdomen, any history of palpitations, dizziness, or sweating while chewing. Past history, there is no history of any similar episodes in the past. There is no history of any major surgeries or blood transfusions, and there are no known illnesses. Personal history, the patient follows a mixed diet. There is no history of any sleep disturbances, loss of appetite, or bowel or bladder disturbances. He's a tobacco chewer and consumes about 1 to 2 packets per day. There is history in the past, there was history of binge alcohol consumption about 2 to 3 times a week, which amounted to 300 grams per week. But in the recent past, he had consumed 210 to 240 grams of alcohol per day for one entire week. There is no history of smoking. Treatment history, there is no significant treatment history. He had not been taking any medication for a long time. And there is no family history. Summary, a 35-year-old chronic alcoholic tobacco chewer, thread maker by occupation, presented with acute onset, rapidly progressive paresthesias of both hands, followed by weakness of the hands, with subsequent progression of paresthesias and weakness to the forearms, feet, and legs over one day, progressing to quadriparesis the following day. My provisional diagnosis is acute onset, rapidly progressive, now static, symmetrical sensory motor quadriparesis without bowel and bladder involvement, without cranial nerve involvement. My primary differentials, given the recent history of binge alcohol consumption, I would first like to place alcohol associated acute toxic polyneuropathy. And then, given the acute progression of the quadriparesis with no bowel and bladder involvement with the mild sensory features, I would like to include the diagnosis of inflammatory polyradicular neuropathy, that is Guillain-Barré syndrome. General examination and vital signs. The patient was
Doctor,
conscious, alert, and cooperative, well oriented to
I
time.
think, Dr. Suvarna, I'd like
Yes,
to
sir.
interrupt. With the history, somebody is coming with the tingling sensations in the lower limbs
Yes, sir.
or upper limbs. So, as you said, rightly mentioned, probably he is having a symptoms of neuropathy,
Yes, sir.
right?
Yes, sir.
Right. What will be the differential diagnosis before he develops? A patient had come to you in the previous night. Before he develops a weakness in the lower limb, if he had come with only tingling sensation, what would have been a differential diagnosis for?
Sir, since in this scenario, my primary differential would have been an alcohol-associated peripheral neuropathy, since there's history of a significant amount of alcohol consumption, even in the past amounting to 300 grams of alcohol per week, and recent history of alcohol consumption amounting to 110 to 240 grams of alcohol per day. Primary differential based on the history, if he had presented only with the paresthesias at that time, would have been an alcohol-induced axonal neuropathy, which would have been chronic. But since he has not given any history of similar episodes in the past, no previous history of such tingling sensations, that diagnosis would have also been provisional.
No. Do the alcoholic patients will present with acute onset of peripheral neuropathy?
Sir, acute onset toxic peripheral neuropathy can be present in alcoholics, given that they had been consuming country liquor or methyl alcohol. If there's toxicity, then they can present.
Very rare. In overnight, one night, do they present with neuropathy, alcohol? Which etiological factors will present with acute onset of neuropathy like that, other than alcohol, maybe preceding factors?
So other than alcohol, acute onset quadriparesis of such uh,
We are not
uh,
talking about quadriplegia. I'm talking only about the sensory symptoms. That is the first problem that patient has complained to us. Come later on, the new symptom that is added is quadriparesis.
yes, sir.
So I am asking, any acute conditions are there where can present with peripheral neuropathy, acute onset?
So we can look into vascular causes. We can look into any recent history of immunization may lead to acute onset peripheral neuropathy. Other than that, if
No,
this it's a
no. See, vaccination. How does it lead to the peripheral neuropathy?
so usually it leads to formation of antibody antigen complexes which cross react with there's molecular mimicry and attacking of the nerve sheaths, and then it leads
So
to
do they present with acute onset?
no, sir. Acute onset might be paraneoplastic or toxin induced or it
Which toxins will present with acute onset of neuropathies?
so lead poisoning may present with.
Okay. Any vitamin will present with acute onset of polyneuropathy. Neuropathy.
Sir, acute onset
I'm not about polyradiculopathy.
acute onset vitamins are so either thiamine or B12, sir.
Yeah. So one thing I just want to tell the mechanisms. We'll go to the next part. The first part I'll try to clear. What are the mechanisms for development of neuropathy in patients with alcoholic liver disease? Alcoholics, you mean to say.
So in alcoholics, the main neuropathy that establishes is the axonal neuropathy, and
I'm not talking about
usually,
the pathogenesis.
yes, sir.
How does alcohol present to peripheral neuropathy?
Sir,
How does alcohol present?
usually,
Mechanism.
So posterior cord
Direct,
involvement
as
is
you
there.
said, one toxin.
Yes, sir.
No, directly the toxin, alcoholic toxins, okay,
Yes,
can
sir.
present
And
directly as a
so there's
neuropathy. That
because of
what are the
poor nutrition.
mechanisms are there?
So because of poor nutrition in these patients, they may also have associated deficiencies of vitamin B, B12, and thiamine. There may be
Yes,
posterior lateral cord
they can
involvement in
have a
these patients.
thiamine.
Yes,
Yeah, they can have thiamine. So
yes.
if the patient is present as alcoholics with thiamine deficiency, what is the disease called as?
Alcoholics with beriberi,
Yes,
thiamine, sir.
what type of berry?
Dry
You're
beriberi.
right, berry. It's a
Yes,
dry
sir.
berry.
Yes,
It is second B one. Third mechanism is vitamin B12 deficiency.
yes,
Right. So
yes.
sometimes acute vitamin B12 deficiency can be precipitated like this kind of presentation in alcoholics. Which other conditions there will be acute deficiency of vitamin B12? Acute deficiency may not be related to this case, but my question is which condition can lead to acute vitamin B12 deficiency?
So a
It is most
tumor.
probably seen with the, who are anesthetists. If they give the anesthetic agent on table, they develop this symptom suddenly.
Okay, sir.
Okay, which is that disease? They
Sir,
give some inhalation, nitric oxide. Okay.
I,
Now coming back to our case, does this alcohol fits into your symptoms? Is it neuropathy or polyradiculopathy?
sir, it can be a polyneuropathy, it can be a polyradiculopathy. It looks like a
No.
polyradiculoneuropathy, sir.
Why not as a neuropathy?
So, because all the muscles and that are supplied by a particular radical seem to be involved the following day. Like there is no movement at all. Initially, there was only distal weakness, and it has now progressed to
No,
involve the
no,
peripheral.
I'm not, see, doctor. So now I'm not going to still the second symptom. I'm just asking, thinking, suppose if this patient, the minus of hemiplegia, this quadriplegia, if the patient comes to our OPD with this kind of symptoms, what will be the approach? Taking first symptom into consideration.
Yes, sir.
So what are the classical symptoms of peripheral neuropathy?
So there may be paresthesias in peripheral neuro. There may be paresthesias. There will be stocking and glove distribution of
Yes.
such paresthesias, and depending on the type of fiber that is involved, it may be a tingling numbness. It may be a burning
No, no,
sensation.
no. I'm asking the hallmarks to diagnose a peripheral neuropathy. What are the hallmarks?
So there's a sensory loss and there is a motor weakness. There are two components to it.
Motor weakness maybe there, may not be there. They may have only
Yes.
pansensory loss.
Yes, sir.
So to say diagnosis of, see, because you're going to differentiate whether it is a polyneuropathy or it is a peripheral neuropathy.
Yes, sir.
So what are the hallmarks to say is a peripheral neuropathy? It has to be bilateral symmetrical, right?
Yes, sir. It has to be bilateral symmetrical. Yes.
Bilateral symmetrical, glove and stocking,
Yes.
right? Most of the time they start with the lower limb.
Yes,
Once
sir.
they go up to the knee, they may involve the upper limb.
Okay.
So this is normal classical history or evolution of the symptoms of a neuropathy.
Yes, sir.
But our patient started with upper limb plus lower limb simultaneously, almost a 1 day duration will
Yes,
be
sir.
there, right? So this goes more for of dealing a case of a polyradiculopathy in this patient, right? Now
Yes.
you take second symptom into consideration. He developed a motor weakness. Now add
Yes.
on to this, and then you talk about motor weakness. The sensory symptoms on the second day was more, or motor symptoms were more in this.
So, according to the history that was given by the patient, the motor weakness was so much out of proportion to the sensory symptoms that by the second day, he was not focusing on the sensory symptoms at all. So, we do not have that history that the tingling sensory, he was just concerned about the motor weakness that he was not able to move. So, the motor weakness was disproportionate to the sensory weakness on day two of the disease, on day
So
two of the.
weakness was more than the
Yes, sir. Yes, sir.
sensory symptom.
Yes, sir.
So what percent of the, so what do you think in this patient, a patient who has initially sensory symptoms followed by the motor symptoms? So this weakness is a part of a sensory involvement or is a motor?
So it is probably it is primarily a motor involvement, but due to the inflammation of the motor nerves, there is some irritation of the sensory nerve as well, which is causing the sensory symptoms.
Right. So most of the times here sensory symptoms are masked and is taken by the motor weakness. So the motor weakness was the most predominant symptom second on day compared to your sensory symptoms.
Yes.
So as you said, one differential diagnosis when you have motor plus sensory, the diagnosis points towards is already you mentioned GB syndrome. Which other diseases will present a sensory plus motor quadriplegia? Motor symptoms.
Sir, porphyrias can present with sensory and motor symptoms. Toxin-induced
You got my
neuropathy.
point. Initially, to start was sensory plus motor. So he had basically a sensory plus motor symptoms without
Yes,
bowel and bladder involvement,
yes, sir.
right?
Yes, sir.
So now, can you tell some diseases where they can have a sensory plus motor weakness, quadriplegia?
So the cord involvement, like a compressive myelopathy or a cord syndromes can present with both sensory and motor weakness, but it will be in further examination.
No,
We
no,
will
we just try to enumerate some three, four causes. Can you tell where sensory plus motor symptoms are there?
sensory plus motor symptoms, so it can be present in compressive myelopathies, non-compressive
So
myelopathies.
basically, cervical spondylosis. We are talking upper limb plus lower limb. So there
Yes,
can have initially plus
yes, sir.
sensory plus motor one like that.
Yes, sir.
Which other
S-
disease?
so there can be foramen tumors of the around the foramen magnum can present like that, but
Why
usually.
sensory there will be involvement? My question is very simple. Sensory plus motor. Otherwise, I will make it very simple. Can you tell me something? Four conditions where you have pure motor quadriplegia.
So pure motor quadriplegia is one is the variants of the GBS, one is critical illness neuropathy, one is uh,
Now,
uh,
commonly you have seen in the emergencies where they are acute. This is a acute presentation, means for 24 to
so
48 hours.
hypokalemic paralysis can
Yes,
present with
right.
that. Sir, other than that, a generalized weakness. Uh,
Commonly you see already one you told GB syndrome,
yes,
right? Second thing, hypophalamic paralysis. Like that, another two conditions where have acute quadriplegia. It may not be applicable to this case, but it's a very straightforward case. But we have to know that the rationals, permutation, combination, these kind of patients come to casualty. How are you
yes,
going to analyze the case or approach the case? That is my idea.
yes, sir. So trauma to the cord can. Uh,
No, trauma is, see, many people, my students also tell me, trauma. It's a very vague thing. Né? As a physician, you have to talk. Any other disease? Can a transverse myelitis come into
Transverse
quadriplegia?
myelitis or high cord, yeah, so yes, sir.
Transverse myelitis, like that. Any other disease?
Sir, uh, multiple, no.
Can multiple sclerosis can present like that?
Sir,
Deep
it
disease.
can present, but usually sensory symptoms are predominant and it has more of a sir, one patch of
Right.
area has
So
more
now
involvement.
you got my point. Now you have put a sensory plus motor. So one of the differential diagnosis for the case will be your one of the GB syndrome. Second is the high cervical cord lesions, where sensory plus motor, sometimes demyelinating diseases.
Yes, sir.
So this is how we're going to approach for it. Now, where you want to localize this lesion?
Sir, I will either localize. Sir, at this point, it can be both a cord lesion or it can be a polyradiculoneuropathy because of the nerve involvement. At this point, without examination, I cannot localize it to either the spinal cord or the radicals.
Okay. Why it is, can any symptoms will tell there is a cord involvement in this
So
patient?
usually if there's a definite sensory level and if there's a bowel and bladder involvement, if there's a back pain, then usually it points towards the spinal cord involvement. But since these features are absent, there is no definite sensory band-like sensation or he is not complaining of any backache and there is no bowel and bladder involvement. It might favor the diagnosis of polyradiculopathy in this case.
See, now you are telling back pain. So back pain will help in a patient who has a chronic, long-standing, slow onset, chronic, progressive quadriplegia.
Yes, sir.
Not in this patient where acute presentation is the
Yes.
first thing. Second thing, most of the times when they have acute presentations, bowel and bladder is very important because you have to
Yes.
always rule if the patient had
Transverse.
developed sensory loss more, okay, transverse myelitis in this
Yes.
patient. But there is no definitive sensory loss in these patients.
Yes.
Okay. Another third thing you are telling that band-like sensation. Band-like sensation is especially helpful for patient when you're presenting with a paraplegia, not
Yes.
quadriplegia.
Yes.
So back pain, your band-like sensation will not apply here for this patient because he has presented with a quadriplegia. To
Yes.
start initially sensory, followed by motor. Later on, motor becomes more predominant than sensory.
Yes.
So it points more towards
Polyradicular.
Polyradiculopathy.
Polyradicular.
So what is the onset of the symptom? It is started from lower limb going to the upper limb.
Sir, it started from the distal upper limbs, then it progressed to the lower limbs
Okay, so
during
the
the
weakness was more predominant in the lower limb, or it is more predominant in the upper limb?
Sir, the weakness was more predominant in the up. Sir, we couldn't actually because from this history, what we elicited was that the weakness started in the distal hands, and then simultaneously by the evening he had involvement of his toes, and then there was buckling in the knees. So, but at that time there was no difficulty in overhead abduction, so predominantly lower limb involvement
So the
as
symptoms
compared.
can start in the upper limb, but if you look at predominantly the lower limbs involved, then the upper limb. So
Yes,
again, it is goes points more of looks to be the ascending type of paralysis in this
yes,
patient. So if you look at that time, the motor symptoms were more than the sensory symptoms. So it is goes more favor of your a polyradiculopathy rather than this localizing to the cord. If there is a cord, we would have had more of a anesthesia or hyposthesia
yes,
rather than the tingling sensations in this patient. So this
yes.
tingling sensation most points towards your radiculopathy, polyradiculopathy, rather than a cord symptoms in these
Watson.
patients. So it is more of looks to be a ascending type of quadriplegia, which is a acute onset, symmetrical,
Symmetrical.
progressive.
Yes.
Right? Can you tell some conditions where you have asymmetrical quadriplegia?
Sir, MND can have asymmetrical
Right.
quadripedes.
We are not going to classify the acute or
Yes.
chronic. I just 3-4 causes of asymmetrical onset quadriplegia.
Sir, MND can have high
Right. One.
cervical compressive myelopathies can have they have asymmetry. Um,
Yeah. Cervical cord lesions. Yes. Compressive
Sir,
myelopathy. Yes.
intradural meningiomas may have if they are in the
Meningioma very rarely. Yes. Any other things?
um, sir
Any non-compressive myelopathy can present with asymmetrical onset.
MS in the cord may have.
Non-compressive myelopathy, asymmetrical onset. Okay. Any vitamin?
Sir, I'm not sure, sir.
Heard about subacute combined degeneration?
Yes, sir.
It is a subacute to start with.
Yes, sir.
They have asymmetrical lesions.
Okay.
Where multiple tracks can be involved.
Yes, sir.
Okay. I think if other professors they want to ask, they can ask the questions.
We may continue to complete the case, sir. In examination section, we will discuss it.
Okay. Please continue.
Good discussion on history. Practically, we should come to the diagnosis by history only. This is the method of medicine. So I think Suvarna has answered most of the questions.
Yeah.
So let Suvarna complete first.
Right. Please carry on with the examination.
General examination and vital signs. The patient was conscious, alert, and cooperative, well oriented to time, place, and person. He was moderately built and nourished, examined in the supine position with both legs extended and externally rotated, arms by the side. He was examined after adequate consent and exposure. Vital signs. Pulse was 84 beats per minute. Blood pressure was 106/80, measured in the right brachial artery in supine position. Respiratory rate was 18 breaths per minute, and he was afebrile at the time of examination. General findings, there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. A single breath count was 32 words. A tattoo mark was observed on the dorsal aspect of the right forearm. And on observation, there was loss of thenar eminence on both hands.
Okay.
High
1 minute.
function.
So now, just go back to vitals. Why you should examine vitals in neurological disorders? What is the importance of examining the pulse in neurological disorder?
Sir, especially in the patients with cord syndromes or like GBS, they may be in a state of spinal shock. They may be in autonomic dysfunction. So we need to examine the vitals, whether there are any arrhythmias, whether there are any major fluctuations in the blood pressure.
No. They have why the GB syndrome is spinal shock?
So not GB syndrome in a neurological case.
My
If
question is very simple. What is the importance of looking at pulse in neurological disorders? 2, 3 conditions you can tell.
so in a patient of GB syndrome, they can have autonomic dysfunction and then they can have
Suppose if
arrhythmias
the
because
patient
of
is
that.
having a bradycardia,
Yes,
Any
sir.
diagnosis of neurological disease will come to know.
A raised ICT we might suspect in that
That,
patient, sir.
that is how it is there.
Yeah.
Importance of measuring the blood pressure in neurology.
Sir,
Three
it
conditions
might
you get.
also point with bradycardia, it can, with a high BP recording will
No,
point to raised
blood pressure,
ICT.
only blood pressure. Just
Sir,
I'm orienting. What is the importance of knowing like this? Three conditions: blood pressure important related to CNS.
so stroke patients have very elevated sir, sir, do I have to answer in general or in relation to this case?
No, general important neurology, and then we'll come to this case.
In neurology, a patient of stroke, if it's an ischemic stroke,
One stroke you want to look for
yes,
blood pressure, right? One, next
yes.
two.
Sir, then in a case of Cort syndrome, if the patient is in spinal shock, the patient may be hypertensive. Or there
No,
may be
not
also
shock. Any
She's not
conditions
a
are
private
associated with
student.
postural hypotension, neurological diseases,
so postural hypertension. So in GB,
neurological disease,
so in GB syndrome and CIDP itself, they can have
not
autonomic
CIDP,
dysfunction and
AIDP.
orthostatic hypertension.
Right. So what is that entity in GB syndrome variant to be very hypotension
So pan dysautonomia will
and
present.
dysautonomia? So that is the importance of there like that.
Yes.
Any other diseases like that? So each vitals when you mention that is very important for us, right? Right. Then what is the important? Your pallor.
So I think your mic has been turned off.
This it is going to help of pallor, icterus, sinuses, clubbing. How it is helpful in neurological diseases?
Sir, a patient whom, especially in this case, which is a case of quadriparesis, pallor may point towards anemia, which in an alcoholic can point towards B12 deficiency, which may lead to which may lead us to evaluate for SACD in the patient, and icterus may also give us, sir, so whether there is hepatic involvement, which further leads to like complications of alcohol associated diseases.
Yeah. So now this case you have to correlate. Whenever there is alcoholic come, if you demonstrate jaundice, patient coming altered sensorium, neurological problems, hepatic encephalopathy, cyanosis, clubbing. How is the clubbing is related to neurological problems?
So, especially in older people, if clubbing is present, maybe an altered sensorium can be suggestive of paraneoplastic encephalopathy in such patients. There may be a carcinoma setting which may be
So
causing clubbing.
you're right. So what I want to say is that whenever you write any general physical finding, just don't try to mention routine, pallor, icterus, cyanosis. In relation to your case, you please try to see that what you wanted to see in GP,
Yes.
right? Go to the examinations.
The
Continue.
sing yes.
Okay, one
Single
more question. Febrile you have mentioned. Can you tell me some fever in CNS disorders?
so meningitis, sir.
One,
Sir, any abscesses which may be causing a compressive myelopathy.
okay.
Sir, any sir, even in malignancies and metastasis, the patient may have low-grade fevers, and
No, no, no. Any CNS disorders will have a fever.
some meningitis.
Okay, meningitis हो गया, common हो गया. और कुछ? Any stroke will have fever?
Yes, so pontine hemorrhages will have
Absolutely. Absolutely.
hypopyrexia.
So,
Yes.
right. So basically, you have to orient that whatever you're going to try the finding, you should know why you are seeing for that these signs. Okay, continue.
A single breath count of 32 words. A tattoo mark was noticed on the dorsal aspect of the right forearm, and there was loss of thinner remnants on both hands. Higher mental functions and cranial nerve examination. The higher mental functions were intact. The patient was conscious, alert, cooperative, and he was able to recall the words that were given to him. Recent memory was intact. Speech fluency was normal. Comprehension was normal. He was able to read, but because of the quadriparesis, he was not able to write. Uh, there were no meningeal signs. There was no neck stiffness or conics. There were no speech deficits. Cranial nerve examination altogether was unremarkable. Motor system examination.
Okay, I just like to interrupt. What is the importance of examining higher mental function in this patient?
So there may be mild deficits in higher mental function, especially in parietal lobe lesions. There is the patient, there is denial of any problem. So if we elicit the higher mental functions in a case of, sir, in this case or in general, like, sir? whether
Now
you
I want
want.
see. Because we are running out the short of time, we'll focus on this patient.
Okay, sir. So the patient may be in minimal HE. That will also help since he's an alcoholic.
I'll give a clue.
Yeah.
He is an alcoholic. So in
Yes.
alcoholics, what higher mental function are affected?
So memory may be affected. Sir,
What about corruption psychosis?
sorry, sir.
Corruption psychosis?
Yes, sir.
Wernicke's
Cortical
encephalopathy?
psychosis. Yes, sir.
Right.
Yes, sir. Yes.
Anything related to your case, thinking as a GB syndrome, any variant can be affected the higher mental
So
function
because
in
stars
GB?
encephalitis may involve.
Absolutely.
Yes.
So that is so basically we wanted to know that you would know in and out about the case about it. Understand? Okay.
Yes.
Can you tell some diseases where cranial nerves are affected with quadriplegia?
So cranial nerves may be affected in brainstem lesions, sir, and compressive
Okay.
high cord
I'll make
compression.
very simple. No, I'll tell you very simple. Third nerve with quadriplegia. What is the diagnosis?
Third nerve with quadriplegia, high cervical cord lesion may be present,
Disease
sir.
you have to talk about. You have to talk about the diseases. Okay. Second cranial nerve with quadriplegia. Okay. I'll become much simpler. Seventh cranial nerve with quadriplegia.
So it points to GPS usually
Absolutely.
50% cases, sir.
GB syndrome. So like
Yes.
that, that is the importance of examining the cranial nerves. Second cranial with quadriplegia, third cranial with quadriplegia, seventh cranial with quadriplegia.
Sir, MS may have second nerve involvement if the asymmetric quadriparesis is present in such patients. Neuromyelitis optica may
Right,
have. Uh,
right.
third nerve.
Okay. So like that. So when you examine the cranial nerves, you have to keep in mind, you have to search their findings. So which ocular finding you get in patient with variant of GB?
So in CIDP, there is papilledema because of the widening
No,
of the.
AIDP. One of the variants of AIDP has a eye findings. What is that finding?
So it is the Miller-Fisher variant which has ophthalmoplegia.
Absolutely. Got my point. So
Yes,
you
sir.
have, I'm just orienting. So when you present, you have to be focused to the case or something related to the case.
Yes, sir.
Okay. I'm focusing only with related to cases surrounding how it will help for the diagnosis. So
Yes,
that
sir.
is the importance of measuring higher frontal speech and all those things. Okay. Can you
Yes.
tell speech with quadriplegia? It's a chronic disease, asymmetrical.
Sorry,
It's a degenerative disorder. It's a degenerative disorder. It's a very common case for AMD. It's a disease of anti cells.
the spinal muscular atrophy and volume.
MND.
MND. Yes.
Right? So each point is important. Okay? Go to
Yes.
the motor system examination.
So, motor system examination. The patient was examined with the arms by the side, legs extended and laterally rotated. There were no evident deformities. The muscle bulk appeared to be bilaterally symmetrical. There was wasting of small muscles of the hand. There were no visible involuntary muscles and there were no fasciculations. On examination, the muscle tone was decreased in all four limbs.
Hmm.
Power in the upper limbs, the power at the shoulder was 1/5. At the elbow, wrist, and fingers, the power was 0. In the lower limbs, the hip, knee power was 0. The ankle dorsiflexion was 0. However, the ankle plantar flexion was 4/5. In this pattern, we see that the weakness was preserved. That the power was preserved only in the plantar flexion of the ankle. The sensory system examination, crude touch, pain, temperature were all intact. The pressure sensations were intact. Vibration sense, joint and position sense, fine touch were all intact. And cortical sensations like stereognosis and tactile localization were also intact. Reflexes, all deep tendon reflexes were absent. Superficial. Superficial reflexes, the corneal reflex was present, abdominal reflexes were absent, and plantar response was bilateral flexor.
Okay. Dr. Suvarna,
Yes.
your reflex is a part of motor system examination or the sensory system examination?
Sir, it is both, sir.
Is
That is why
how
we
do you
mentioned.
examine a motor system? What are the headings you examine for motor system?
Sir, in the motor system examination, we see the the general how the patient is lying, and then we see for
That is GP. That is in general physical examination. When you do proper motor system examination, under what headings you examine?
so muscle bulk in any
Bulk.
involuntary movements, the muscle
No,
tone,
no, no. First is what is
muscle
your
bulk,
muscle
bulk and
bulk?
nutrition.
Nutrition. Right.
Yes, sir.
One. Next.
Muscle tone,
Yes, two is the tone. Third one.
power,
Power. Right.
then sir, coordination,
Reflexes.
reflex. Okay, sir.
Then coordination.
Okay, sir.
Right. So these are under headings you have to examine a motor system. Then comes a sensory system examination.
Sir, I had a small doubt, sir.
Yeah.
Sir, since the reflex arc comprises of both the motor and sensory components, how will we able to tell whether the sensory component is impaired or the motor component is impaired if we first mention the reflexes and then mention the sensory examination?
No, that is a part of many of the standard books have been mentioned that you have to examine the reflexes followed by the sensory system examination.
Okay, sir.
And reflex arc, only few conditions are there where the sensory arc is affected. In a reflex, for example, diabetes, syphilic, afferent
Yes.
fibers are affected.
Yes.
So motors, for example, you take example of stroke. How do we examine reflexors or sensory system first?
Reflexes.
Absolutely, right? Continue. So if you look at what is the summary of motor system, what you examine presented.
The summary of motor system is that there is hypotonia and areflexia.
So hypotonia is very important. Tell some 4 diseases where you get a hypotonia.
Sir, hypotonia may be present in GBS. It may be present in poliomyelitis. It may be present in peripheral neuropathies. It may be present in and anterior horn cell diseases like spinal muscular atrophy. We may
You
have
are all telling LMN is one of the cause. Can we get a hypotonia in UMN diseases?
so in the case of spinal shock, we can get hypotonia.
Any other disease system where you can get hypotonia?
Sir, a generalized systemic disease like
No,
myasthenia
no.
gravis.
Generally, systemic disease is different. I am talking neurology causes for hypotonia.
So
Element
cerebellar
definitely.
lesions may have hypotonia of the ipsilateral side.
Any extrapyramidal symptom will have hypotonia?
Sir, extrapyramidal, sir, usually has rigidities.
Yeah, one which is the disease has hypotonia. Okay, study on that.
Yes.
Okay, continue. Can you UMN it when you get a hypotonia?
So in UMN, in the state of spinal shock, the patient will present with hypotonia.
Right. So any of the diseases can have a hypotonias.
Yes.
Okay, continue.
Other findings, gait and cerebellar signs. The gait could not be assessed, and the cerebellar signs could also not be examined. However, there was no evidence of nystagmus. So this was examined because since the patient was a chronic alcoholic, he may have associated cerebellar features. That is why we examined the cerebellar signs. There was no evidence of nystagmus. The spinal examination, there is no deformity, and there is no knuckle gibbus or kyphus, and there is no spinal tenderness. A test for autonomic function was done in this patient, considering a diagnosis of polyradicular neuropathy. Since other tests were not available, we did a deep breath holding test for the patient, and the differences between the maximum and the minimum heart rate were taken, and they came to be within normal limits, and it was the heart rate increased by 15 beats per minute. Other system examinations were unremarkable. Cardiac, respiratory, and gastrointestinal systems were unremarkable.
Okay. Did you look for this patient is having dysphagia?
So the patient did not have any dysphagia. We specifically asked whether there was any difficulty. And sir, I have mentioned that in my history. There is no history of difficulty in swallowing. There is no history of nasal regurgitation of food. There is no differences in swallowing solids or liquids. There is no
Right.
such.
So if we summarize all the important CNS findings in this patient.
All important CNS findings. And sir, I have the summary over here. May I?
No, important findings such as.
So important CNS findings were that there was areflexia with hypotonia without sensory loss, without uh, any autonomic disturbances.
But if you
And
go back, you are telling there is small muscles wasting of small
sir,
muscles.
the small muscle wasting has been attributed to the fact that he has been in a state of quadriparesis for the last 20 days, more than 20 20 days. So we are attributing that to disuse atrophy,
No,
sir.
but he is using the hand, he's
No,
moving
sir.
mobile, everything. He's
So
bedridden.
that was on the day of the beginning of the illness. Ever since then, the patient has been quadriparetic.
So only small muscles of hand wasting is there. No other
Yes,
muscles are there.
sir. When the patient had presented to us, he had already been treated with fluids at an outside hospital.
Okay.
We could not appreciate the wasting in the forearms and the legs because of the peripheral
So that,
edema.
that is not so much important for me. So now the
Yes,
question
sir. So
comes
we could only
whether,
notice the wasting in the hands.
so now question is whether it's a disuse atrophy or it's true wasting.
Sir, disuse,
How to differentiate? No,
sir,
20 days
waste.
is very too short time. So
Sir,
how to differentiate clinically?
patient did not have any
No, no,
fasciculation, sir. It did not
Dr.
seem like
Suvarna,
a.
listen to me. How to differentiate a disuse atrophy from a wasting? Because he has a polyradiculopathy, wasting is there. How to differentiate?
So there were no fasciculations, and the generalized.
Very rarely fasciculations you get nerves. It is a hallmark of your anterior horn cell disease. Understand? So
Yes.
bedside, if somebody asks you to know that whether this patient is a disuse atrophy or wasting, what do you do bedside? What are the tests to do bedside to disuse atrophy versus wasting? I look for the hand grip.
So in this patient, we were not able to perform that. That is why we are not
Okay. Have you must
performing the
examine
hand.
for the small muscles of the hand?
So the small muscles of the hands, but the thenar eminence was wasted. That is what.
What about the intraosseous, palmar and dorsal?
So the patient was not able to make any movements in the hands
Why?
at all. So that was his complaint, sir. So he has not been able to
No.
move any of.
What I want to say, if you minus that point, remaining case discussion is going smoothly. But you have to analyze that symptoms.
Yes,
Whether
sir.
it's a soft sign, should we take into consideration or not? Whether it is related to our case or not. So everything has to be analyzed.
Yes.
You got me? There is a main idea about this is that this finding is not explainable. Whatever you're told, hypotonia, reflexes are absent. That is explainable. History is explainable. But this kind of odd findings, you have to give explanations for that. Why for that?
Sir, I had included this because at the time of presentation, the patient had already crossed 3 weeks of quadriparesis. So we attributed this feature to disuse atrophy at the
Absolutely.
time.
So that's what I'm asking. Bedside, what are the signs to differentiate disuse atrophy from a neurological
Sir,
disease?
if the patient was able to move his hands, then we would have done a hand grip to assess the power of the hands.
So you have to look here. You have to check individual muscles, and if there are large group of muscles are there, here that though they have flabby, the power will be normal.
Yes.
Reflexes will be preserved in these patients,
Yes.
right? Okay.
Yes.
Diagnosis. I think we are short of 10 minutes. Diagnosis.
The final clinical diagnosis, sir, acute onset, rapidly progressive, now static, symmetrical, pure motor, element type quadriparesis without cranial nerve involvement and without bowel and bladder involvement. The final differential is polyradicular neuropathy, query Guillain-Barré syndrome, a pure motor variant.
So what are the three hardcore symptoms and signs to tell it's a GB syndrome?
Sir, it is acute onset. There is rapid progression of the disease. There is quadriparesis. There is hypotonia. There is areflexia, which all point towards the diagnosis of.
Areflexia.
Yes.
Important hypotonia, areflexia is very, very important finding to
Yes.
suggest. Okay. Can there be bladder involvement and bowel involvement in this patient, GB syndrome?
Sir, usually bladder involvement is a rare finding, but it may be present in these patients. Usually there is a denervation of the urethral sphincter because of which there is a bladder involvement in these
Yeah.
patients.
So this patient can have sensory symptoms subject to 50% of the patient. 20 to 30% patient can have bowel and bladder involvement,
Yes.
but they don't have objective evidence. Objective evidence they can present only with clinical finding of motor weakness. But
Yes.
these symptoms can be present in these patients initially.
Yes,
The
sir.
patients, as you started, 50% can present with sensory symptoms in these
Yes,
patients.
sir.
Right?
Yes, sir.
Oh, right. Now, how do you like to proceed with this case?
Sir,
Now you
general.
have to confirm your diagnosis in short.
So to confirm the diagnosis, we will start the evaluation of the patient. First we will go with the general investigations. The CBC and the other blood workup in this patient came out to be normal. However, we could have expected anemia in the patient because he has been a chronic alcoholic.
Okay, there's an
Six.
additional finding to an alcoholic, not support to diagnose for neurology.
Sorry, sir.
This fine. This routine CBC will help to diagnose of alcoholic related problem, not for your neurological problem.
Yes, sir. Yes, sir. Yes.
Okay.
So then we proceeded first to screening of the spine. An MRI cervical spine was ordered with screening of whole spine, which was unremarkable. And
Okay.
then we proceeded to nerve conduction studies. There was decreased amplitude of the compound muscle action potentials. The conduction velocity was normal and the sensory nerve action potentials were normal, which was suggestive of an axonal pure motor pattern of involvement.
Okay. What is the role of MRI in patient? Any patient who come with the quadriplegia?
Sir, any patient with a quadriplegia, if we are suspecting a spinal pathology, then even if the patient is in a state of hypotonia, he may be in spinal shock. So we have to rule out a cord pathology first before proceeding, because even in mute plantars, it would point towards a diagnosis of
So you have to rule
UMN
out
lesion.
structural diseases. So
Yes.
what, by looking at the spine, what diseases you can diagnose quadriplegia?
So just by looking at the spine,
MRI
sir,
spine, you order the MRI spine and you find something abnormal. What are the diseases you can diagnose in MRI spine?
so there may be a cervical craniocervical junction anomaly may be present. There may be a
Very rarely, sir.
tumor.
CB junction anomaly is very rarely.
Yes,
Okay.
sir.
You want to look for compressive, like in the form of spondylosis.
Yes.
Non-compressive lesions, what you want to look in these patients?
Sir,
What findings would
MS,
you like to look for that?
sir, in MS there may be a hyperintensity present.
Yes. So you have to look for the demyelination disease in the
Yes,
form of hyperintensity.
hyperintensities.
We can go one step ahead. So you have to look for number of segments involved.
Longitudinally extended LETM we can.
We can go for into neuromyelitis opticans.
Yes.
Any other diseases? Any finding for you can get in patients with that of transverse myelitis?
Transverse, sir, hyperintensity at a section of the spinal cord may be present.
Cord edema at that
Cord
level.
edema, sir. Yes.
Okay. Can any findings with vitamin B12 deficiency in the spinal can we make out?
So there will be posterior column enhancement in these patients.
If there are any cavities in the spinal cord, serings we can make out.
Serings, yes, sir.
So basically, secondary causes for quadriplegia or GB syndrome you have to rule out in this patient. It may not help in the diagnosis. To confirm your diagnosis, you have to look for nerve conduction studies.
Yes, sir.
Other these findings, any other finding you do like specifically for your GB syndrome?
So a CSF workup was ordered for this patient.
Okay, we'll interpret CSF. Chalo, another 5 minutes, 2 minutes, right?
Sir, there were 6 cells which were 100% lymphocyte predominant, a protein of 106, sugars of the CSF were 102, and RBS was 136. This was suggestive of an albuminocytological dissociation.
Okay. Whether it can be normal in patient with GB syndrome?
Sir, it can be normal within the first week, especially within the first 48 hours.
Right. If you do in first 7 days, it will be normal. But already when you are doing NCV,
yes, sir.
why did you do CSF findings in this patient?
So usually it is not required.
Not required.
Because we have established through non-invasive testing that it is that.
Okay. So what else you see in nerve conduction study apart from the amplitude?
So conduction velocities are also looked at.
Yeah. Any other specific way you tell that initial part if you look that? Okay.
So F wave latency
Absolutely.
is long.
So the absence of F wave is very important finding. Yes. Okay. Then you want to look for the amplitude and your conduction velocities.
Yes.
That will tell us whether it is axonal or demyelinations.
Yes, sir.
And that prognosis will depends upon your NCV, whether patient is respond to the therapy or not. So when you look for the NCV, you have to look for the F wave, you're going to look for the amplitude, you're going to look for the conduction, you're going to classify the prognosis in this patient, who is going to respond for your immunoglobulins, okay, or plasmapheresis. Okay, continue.
Snaps were normal in this patient and you have the symptoms of tingling. How will you explain this?
Sorry, sir, I can hear you.
Snaps are normal in the NCVs and you are telling that the symptoms started with tingling sensation. How will you explain
Sir,
this?
even on examination, we confirmed that there was no sensory loss in the patient. So the tingling sensation was attributed to irritation of the nerve fiber rather than involvement of the nerve fiber, sir. Because there was involved, so in the muscle, in the mixed nerve, there was involvement of the motor fibers of the nerve, and because of the inflammation, there was irritation of the sensory fibers, which could have led to sensory symptoms. However, on examination, there was no sensory loss, so the snaps were normal, sir.
So now NCV is done for a small fiber neuropathy or a large fiber neuropathy.
Sir, NCV gives us insight into whether it is a small fiber neuropathy or a large fiber neuropathy. Even it can tell us whether
Done
it is demyelinating, which can be large fiber neuropathy,
no,
and it tells
it
us
whether it is done primarily for a large fiber neuropathy or a small fiber neuropathy.
sub large fiber neuropathy.
And for small fiber neuropathy, what we have to do for that?
Sir, EMGs.
Somatosensory response we have to them. What does that tell to you? In a neuropathy, what does SSR tells about that? You have not done in this patient. No. It tells whether autonomic involvement is there or not, because small fiber neuropathy usually denotes that there is a
C5
involvement
positive.
of autonomic nerve, small fiber nerves, autonomic involvement is there or not. And it is very important in this case. So it should be done. And the symptoms started from the upper limb. The power was also weak in the upper limb, and then lower limb was involved. What the secondary investigation we have done to rule out in this case that the secondary causes has been ruled out, and the
Sir,
GBS.
secondary causes of GBS, sir, we had also given retrovirus hepatitis B and C panel for this patient was done. Other than that, sir, since the routine investigations came out to be normal, and so the other secondary causes usually include retroviral disease or hepatitis E or CMV or mycoplasma. Sir, at such so
Any other
given
thing? Any other thing? Apart from infection and all, have you seen for paraproteinemias in this patient?
paraproteinemias, no.
Because the one thing is atypical that the symptoms started from the upper limb and then went to the lower limb.
Yes.
And the weakness also started in the upper limb and then went to the lower limb. And you have this axonal variant of this NCV, but the symptoms looks like demyelinating type because both upper limb and lower limb are involved within 1 to 2 days. And so I think that secondary causes should be ruled out in this patient. Just going to tell that it is a GBS because GBS typically presents with a ascending type of paralysis, not a descending type. If there is a descending type, we should think about any secondary cause. And then how will you explain this plantar flexion power of 4/5? All the are
S-
1/5, 0/5. Only
Sir,
plantar
since
flexion is 4.
sir, since it is a polyradiculopathy, the extent of radicular involvement may be variable. So we had attributed that to this fact.
What is the difference? How will come to know that it is a polyneuropathy or polyneuroradiculopathy?
So if if only the nerve is involved, uh, so usually root gives off the posterior and an anterior ramus. If you want to establish diagnosis of radiculopathy, the posterior
Symptoms. What are the symptoms that tells that this is the.
radiculopathy will, sir, have a radiating character of pain associated to it.
But in this patient, we didn't have this.
No, sir.
And next other
Sir,
thing.
the fact that there is a CSF albuminocytological dissociation gives us a clue that it is a radiculopathy.
Uh, okay, but how this polyneuropathy and polyneuroradiculopathy? In polyneuropathy, usually it is a distal involvement first and then proximal. But in radiculopathy, it is proximal first, then distal. Usually, this is because radicals are involved, so proximal weakness is predominant. And when it is polyneuropathy only, so that at that time it will be distal weakness, and then it will go to this proximal weakness. But in this patient, there was no pain, only tingling and then weakness.
Yes, sir.
And patient is having only these snaps are decreased. So when the snap is decreased, then there will be many things that will come in consideration because it is axonal type variant. In axonal type variant, we have to think about few more differentials because in if it is demyelinating in NCV, then it is as per se that the patient is having a nerve disorder. But if
Yes, sir.
there is only snaps are decreased, it can be due to NMJ disorder, it can be due to muscle disorder, it can be due to nerve disorder. So when there is only snaps decreased, we have to take many things in consideration.
Yes, sir.
Aman variant GV syndrome is one, but there can be NMJ disorder, acute onset myasthenia crisis. We can have an acute presentation with that involving with bulbar involvement and all. We can have that, and in this acute myopathies can present with this. So when only snaps are decreased, then we have to think of many things, not only nerve. It can be muscle, it can be neuromuscular junction. And as Dr. Dhyanesh has pointed, atrophy, how you can explain that in this patient? What was the occupation of the patient?
The patient was a thread maker. He used
Thread
to
maker.
weave threads.
Then how only thinner muscles were wasted in this patient? And if a patient is having a weakness uh, due to anterior horn cell or any peripheral neuropathy, then what is the duration after which the atrophy develops?
So usually a denervation atrophy, which is due to a LMN type of lesion,
Yes.
is usually faster to develop because the muscle is completely devoid of the
The
supply.
duration, I want the duration. What is the duration? Because specifically we ask after certain duration that we have to go for a EMG examination.
So it may set in within weeks.
Usually it is usually after 14 to 21 days that we start seeing the denervation, yes, spontaneous activities and denervation potentials we have seen. So doing EMG in early phase, we do not get anything. So when you do it after 18 days, 20 days, we start getting this spontaneous activity. So atrophy also settles after 21 days on, not early.
Yes, sir.
And
So the
so
patient
I
had
think that,
presented to us after 20 days. So
okay. But suppose that you have a cervical cord involvement. What is the sign that tells that it can be a cervical cord myelopathy that we have to see in a quadriparasitic patient?
so
What is it?
Lermite sign.
Yes, you have to ask then a patient may tell that when I flex my neck, there is an electric shock-like sensation. That is also a pointer. In MRI, if there is a cervical cord involvement, suppose that Danish have told that it is less than 3 segment, more than 3 segment. If it is less than 3 segment, what you will think about?
So it can be MS. It may not involve.
Another
Sir, it can be metastasis. Sir, it can be.
in demyelinating disease, metastasis will have a compressive lesion. Mogad can present with a short segment and a long segment both. Suppose that a patient is having only a quad equine type presentation with a paraparesis, and the patient is having a lesion in this quad equine region, then what you will think about in demyelinating disease?
Just a cord equine.
Suppose that acute onset within 3 to 4 days presenting with paraparesis, then MOGAD is a possibility because MOGAD usually present with lumbosacral region, and then we have to do the evaluation for that. In this patient, I think that we should go for a paraproteinemias because it is not a simple like GP syndrome. So we should go. What is the treatment response in this patient?
Sir, that is one thing which I wanted to point out. The patient presented to us after 3 weeks and the weakness had become static. So, after 3 weeks, we did a general evaluation and a decision to not further treat the patient with IVIG or plasmapheresis was taken since the weakness had plateaued and the first 2 weeks had passed.
So what is the simple thing that you will see in the patient and you can give this IVIG even after 14 days? What is the one thing?
Sir, the
Clinical thing.
autonomic
No.
disturbances.
No. What is the functional ability of this patient which we see, whether he can go for a 10 meters or not, whether
The
walk for
patient
10
is
meters.
quadriplegic ever since
Then
so
so
we
then
बैटरी खत्म हो गई फिर
if
चार्जिंग पे लगाते
if
हैं
he is a quadriplegic, then even after 14 days we can go for IVIG, because now the dictum is that if a patient cannot walk for a 14 for 10 meters, then we can go for IVIG. And plasma pheresis we have done in this patient.
No, sir. We did not have that facility available, so we could not. We then
And-
referred the patient after that to a higher center, and we had advised plasmapheresis for him.
And in USG, any organomegaly
No, sir. There was no other significant finding in the patient.
and fundus examination?
Fundus examination, sir, was within normal limits. There was no evidence of papilledema or any other.
So even though now what is the day of that patient, illness of the illness
Sir,
date?
he presented to us on day 21 of illness.
So now he's admitted or not?
Sir, the patient has now been discharged after 3 days of
No
admission.
improvement. No improvement now.
No, sir.
Sorry to interrupt, Dr. Abhay and Swarna. We are running short of time. So
Okay.
can we conclude, sir?
Okay.
Just before concluding, I'll take just 130 seconds.
Sure.
Abhay sir, so what are you telling the secondary causes? Because there are no
Yes.
structural lesions, compressive, non-compressive, MRI is almost ruled out. Second thing, as a physician, I try to look whether the ESR is very high. It will give some clue for us.
Yes.
LFT,
Yes.
if your albumin to globulin ratio is changed, we try to think something like paraproteinemia.
Paraproteinemia disease.
So those are some clues we can pick up from the other investigations also. Should we go ahead with that? Because normally we look into the LFT where the ratio changes, albumin and globulin ratio.
Serum electrophoresis can be done in this patient. It is easily available. We can go for that.
Yes, sir. Yes, sir. That is a higher investigation. What I'm saying, in a routine investigations, even a LFT can give a clue
Yes.
whether we are doing something paraproteinemia. ESR, your globulin to albumin ratio. So those can pick up clue. Sometimes you can get any profile. I don't know we should do in this patient or not.
Okay.
Like that. That is my opinion, sir. I don't know.
Okay.
Thank you from my side.
So I think that was a good case, very good presentation by the student and very good discussion by all the panelists. May I invite Dr. Ravi Kirti, sir?
Good evening, everyone. Am I audible?
Yes, sir.
I think we've had a very fruitful discussion, and I must congratulate the candidate for having presented the case so well. Especially the history was presented very well. Often I find with many of the students, rather than describing the actual sequence of events, people just use labels like pediatric onset, gradually progressing, and so on. Rather than doing that, it is a very good idea to actually describe the sequence of events, which he did very well. So the history was presented very well. And of course, you asked so many questions and managed it very well, so congratulations to you. And the mentors and the experts. Probably running out of time. I will not take any further time. So thank you very much.
Thank you, sir. This all case presentation has been recorded. It was simultaneously aired on YouTube also. So we have YouTube recording. I will place it in the group so all the other candidates can be benefited. I think it is a very good presentation, and all the PG student must go through the YouTube recording, and this will really help you in future in preparation of the cases. So, Gautam sir, if anything is not there, then we will
I think
proceed with.
every good discussion was there, and Suvarna also excellent, very nicely presented the case, and I think answered the most of the questions also. So I think Dr. Adit is there. If another panelist want to add something, otherwise we'll conclude. Dr. Adit is there.
Yes, sir. Yes, sir. I'm here.
Yes,
Uh,
yes. Okay. You want to say
Good
something?
evening
Yeah.
to yes, sir. Happy Doctor's Day to everybody. And I am just glad, sir, and feeling proud that our student presented so well. I just want to add one thing for rolling in the diagnosis of GBS in basically younger age group or children where NCV is not possible or they are not cooperative or sedation is not possible, then MRI findings can help and when we find some intrathecal radical basically thickening. So we can somewhat get clue that yes, based on our clinical history and examination and these findings, we can move towards the diagnosis of GBS. And I think everything was covered very well. I do not need to go further, sir. Thank you, sir.
Okay.
Uh, Thank you, sir. May I request Dr. Princey Jain to propose a vote of thanks?
Good evening, everyone. First of all, happy Doctor's Day. And it's my privilege to propose a vote of thanks on the behalf of CCDSI. Thank you, Dr. Abhishek. First of all, I would like to express my heartfelt gratitude to our founder president, sir, Dr. A.N. Rai, sir, as for his constant guidance and blessings. And then to our president, sir, Dr. Parikh, sir, and Dean, sir, Dr. Varmani, sir, for their unwavering support and encouragement in making the academic initiatives a success in CCDSI. I would like to sincerely thank Dr. Danesh Morka, sir, for conducting today's session so nicely, and our expert, Dr. Abhay, sir, for sharing his valuable insights and enriching the discussion with his vast experience. I also like to congratulate Dr. Suvarna for her excellent case presentation, Dr. Suvarna.
Thank you.
And thank you, Dr. Aditya Kumar, for the scientific discussion and learning point, which are the takeaway points for all of us. And a special word of appreciation for Dr. K.K. Lohani, sir, a moderator and chairman scientific committee, for his continuous efforts in maintaining such a high standards of CCDSI webinars. Thank you, Dr. S.K. Gautam, sir, and Dr. Siddiqui, sir, for the meticulous planning. I also extend my sincere gratitude to all the faculty members, students, and participants from across the country for their enthusiastic participation. And lastly, I thank the executive secretary and secretary, Dr. Mitunjay, sir, and Dr. Abhishek, and the entire organizing team of CCDSI for their hard work behind the screens and ensuring the smooth conduct of these webinars. So, with this, we come to the end of this session, and thank you all for their valuable time and participation. So, thank you so much and have a pleasant evening. Now we come
Thanks,
wind up with the session.
Thanks, Princey. In the
Thank
last
you.
moment, I involved my senior, Dr. Ravi Kirti sir, and sir was there for throughout the time. Thank you, sir, for again rescuing me. I worked under Dr. Ravi Kirti sir in NIMS Patna, so whenever I got entangled, I call her, I call sir, and sir helps me to get out. So, because of the various celebrations of Doctors' Day, our dean sir was not available. So, Ravi sir did the part of the dean sir very well. Thank you, sir.
Thank you, sir.
Thanks again.
Thank you. Good
So,
night, all.
thanks,
Yeah.
Princey. Also, we may conclude. And again, very, very congratulations to the student because presenting to uh, this quality of audience and such experienced teacher is a difficult task. And she faced the question very bold, in a very bold manner. So, again, congratulations. And thanks to Dr. Dhyanesh sir teaching should be done like that. So at each and every step of the history, you have to think about what is happening to the patient and what is my diagnosis, in which direction I am going. So this discussion was very fruitful. This CMA will be remembered for long, at least
Thank you, sir.
amongst the PGs. So, Gautam sir, with your permission, we may conclude now
Yes,
and
definitely.
stop this
Uh,
session.
I would like to thank all the panelists and all the chairpersons, and especially thank Dr. S.K. Gautam and Dr. Aditya sir for the opportunity and the continued guidance. Thank you so much, sir.
Congratulations, Dr. Suvarna.
Thank you.
Well done.
Okay, well done, well done. Okay, good night to all. We are now
Good
Good
stopping
night.
this.
Good night.
Good night, sir.
Ending this
Good
session.
night.
Good night.